right. Let's move on to our next speaker. I am personally really excited to introduce our next speaker, Dr. Matt Spraker, not only because he's an accomplished radiation oncologist, but because he played a very critical role in my own care. And today, he's here to educate us on radiation therapy in sarcoma. Dr. Spraker is well known in the sarcoma and broader cancer community for his dedication to patient-centered care. He and his team work hard to communicate complex medical information clearly and educate patients about their treatment options and their health. Beyond his clinical work, Dr. Spraker hosts two insightful podcasts, Oncology Unscripted and The Accelerators, aimed at educating both cancer patients and healthcare professionals. Welcome to Change, Dr. Spraker.
Thanks a lot. I appreciate it. Let me share my screen here. All right. Are you able to see this okay?
Yeah.
Okay. Is it like the regular? Hopefully it looks like the regular slideshow now.
It does,
All right.
yes.
Okay, cool. So I'm going to just jump in because I want to make sure that I stay on time and I want to stand between you and your lunch. And I think that it's important to start any talk about radiation therapy with just a discussion of what it is, because I think there's a lot of confusion about that out there for patients. And I like to remind people it's actually the oldest radiotherapy is the oldest cancer treatment. And just to give people some context, this is Wilhelm Röntgen, who kind of discovered X-rays in general. A lot of people might think of it in the diagnostic realm, where you use these to make pictures. But pretty quickly after these were discovered in 1895, people were starting to talk about treating them because they noticed when they were taking pictures of people with X-rays that they had some tissue reactions, things like inflammation and even tumor cells that were kind of shrinking away. And I'm not going to be able to cover everything about radiotherapy in 40 minutes. And so I want to focus on what people commonly get in the sarcoma world. But just realize you can get radiation in a lot of ways. You might hear of things like brachytherapy, which is kind of more like a surgical procedure that implants radioactive devices kind of into the patient. But what most people get in most situations in sarcoma is external beam radiotherapy, where you lay on a machine. This is actually the machine that I use at work. We have a team that runs it, and the way it works is you lay on this table here, and then basically this machine makes beams of radiation that come out of this very complex piece of machinery at the top. And then we have some panels that are able to take pictures of patients, do X-rays or cone beam CTs to be able to identify where parts of their body are that we want to treat. And this is a very advanced machine, come a really long way in the last 20 years or so. And I'm going to try to highlight some of those advancements and how that impacts patients with sarcoma. So just from a very high level, I think it's important that people understand the value of radiation therapy in this field. And in sarcoma, it comes up pretty frequently. We're a member of the multidisciplinary team that treats patients. And in the curative setting, it's really the standard of care for saving limbs. What I mean by that is that most people used to get amputation for this many, many years ago. We've had some clinical trials through the 90s and 2000s that now shows that most patients are best treated with more limited surgery and then adding radiation therapy for tumors that are at risk of coming back. So it's really playing a big role in the curative setting there. SARC-32 was a trial that's mentioned earlier. That's kind of the most recent radiation-based trial that was looking at combining with immunotherapy in that setting. We also are very important for ablating metastases, and that means when the cancer spreads, we can actually use radiation in a way a little bit like radioactive surgery, where we can give a very high dose of radiation that makes the tumors die completely, as if it's sort of like taking them out, but without the surgery. And in some other cancers, we found that SBRT or ablative radiation can be used to even delay the use of chemo in selected patients, and that might be a good strategy some patients might hear about. It's also a very important treatment for palliating pain and other symptoms in all types of cancer, but also in sarcoma. And so how does it work? It's too hard to cover all of this in 40 minutes. And so just some very high level, radiation therapy is delivered in daily treatments. You basically lay on that table each day. And most treatments in the sarcoma world range from about 1 week, more like palliative or ablative radiation setting, all the way out to like 6 or 7 weeks of treatment, up to 35 treatments for a given treatment course. Sometimes we combine with our medical oncology colleagues and we give systemic therapy together with radiation to make it work a little better. And then the side effects tend to be tissue dependent. And so what that means is if I'm treating in your chest wall or your arm, it's unlikely you're going to have a lot of side effects affecting your legs, for example. So it's not quite chemo, it's not quite surgery, it's something in between, and it has elements, I think, that are related to the patient experience, kind of both. But what I tell all my patients is that at the end of the day, when we give the radiation treatment, the effects both on the tumor and the patient are related to the dose per treatment, the total dose that people are getting, and then the size of the field. Those are things that I think about in addition to kind of where we're treating. Now, there are lots of complicated graphs about this, but I wanted to kind of give an important point about how radiation works in people's bodies, and I'll ask you to ignore this blue curve. It is important, but not for this part of the discussion. This is showing for increasing radiation dose from left to right, we can have an increase of probability of, for example, normal tissue damage. So this could be like a side effect or a risk of a complication from radiation. And the key point is that at very low doses, the probability of harming the tissue with lower doses is basically zero or very, very low. There's substantial controversy about the effects of very low doses of radiation, but for the purpose of this talk, it's very safe to give it and people won't even feel it. But as you raise the dose of radiation to any given tissue and you go to up to a certain dose, pretty quickly things jump up and you have a high probability of causing a complication. And so a lot of our technology has really been driven over the last 30 years to basically confining the amount of high dose that's treated to patients, basically to the tumor tissue. We want to kill the tumor, so we don't care if bad things happen to it. And then trying to use strategies that might add some low dose to achieve that conformal high dose, just to make sure that the side effects are limited. And so how this actually works in practice is, remember that big treatment head that I showed? It has a lot of sophisticated equipment inside of it. One of them is it actually has these little kind of fingers or teeth-like structures that are very thick pieces of metal that actually block the radiation coming out of the machine. And so we can deliver multiple beams of radiation with different shapes. That's kind of what it's showing here. And if you add them up, this is a way that we can keep the high dose really limited to the area that we're trying to treat. So this is an example of a head and neck patient. So you might have, for example, a sarcoma in the head and neck area. Those are rare, but they do exist. And let's say the tumor is kind of right around here, and I'm asking my beam of radiation to give radiation here, but let's avoid all the important stuff like the bottom of the brain or the salivary glands out here. By the way, this is a slice through a patient's head. Here's the front, here's the back of their head, here are their teeth, for example. And what I'm showing you is the old way of giving radiation on the left. We call that 2D radiotherapy. And then over the years, we've invented 3D, which is basically computer-based planning that allows us to arrange the beams better. And then now what's standard of care in sarcoma is to use what's called IMRT, using lots of beams to keep that high dose very limited to the area we want to treat. And what you can see is that we spare more structures over time. This is showing the high dose. So in this IMRT version, there's a lot less dose going to things like the salivary glands. And we found through trials that if we do this kind of a strategy, people report out less symptoms related to this tissue. So this patient in the IMRT on the right will be expected to have less dry mouth because the salivary glands will be healthier through treatment than if we treated them with 2D radiotherapy, like a strategy we used to use back in the 80s or 90s, for example, prior to computers. And so functionally, at the end of the day, what sarcoma patients get nowadays with radiation compared to when we were running our original studies 20, 30 years ago, is that the fields that are delivered to patients, the ones that can cure the tumor and cause side effects, are much smaller than they were back then. And so these days, things are more personalized, mainly to your anatomy, but we now have examples where we might do less dose for certain types of sarcoma, for example. It's less toxic. That's been shown in clinical trials that people have less complications, less side effects. And if you ask patients through patient-reported outcomes, they have better quality of life in the long run. We just have a better understanding of how this works. So let's run through a couple of cases just to kind of exemplify these points. And I just want to point out these are hypothetical cases, but based on true events. Some of the pictures are real, but I've changed the details just to maintain the patient's privacy. So let's start our first case of the extremity with a 56-year-old woman with a lump on her elbow. So she goes into the doctor, painless growing mass. If that happens and people are in their 50s or 60s, they should head to their primary care and kind of learn more about it. And we get a standard sarcoma workup where patients can get an MRI. This measured about 6.4 centimeters, making it relatively large. It was superficial to the muscle, and there were no metastases noted. So it's a localized sarcoma that's pretty large. As you've heard, there's a lot more information that we do get about these tumors, but for purposes of radiation, we just really need a biopsy here, and it shows a pleomorphic sarcoma that's high grade. So key point, large high-grade tumors, those generally, as a standard, are treated with radiation, including prior to or after the surgery. And so we decided ultimately to treat this patient with radiation before surgery. And what I'm showing you here is kind of what I look at or how I do this. What we do is we take a CT scan of the patient in the treatment position. I'm showing you a pretty zoomed in picture of her elbow area here. This is the front of the body, the back. Here's the long arm bone, the humerus that heads up towards the shoulder. This is kind of towards the bottom of that, towards the elbow. And right here is that sarcoma that's sitting outside of the muscle. And remember, we've already had a multidisciplinary discussion that they're going to have surgery. So basically what I do is I tell a computer, here's the tumor, here's the bone, here's the muscle. I want to spare some lymphatics. I think we had a talk about exercise earlier today where they talked a little bit about lymphedema management. And we will basically design these radiotherapy treatments to minimize dose to those things that I'm worried about while I'm giving a high dose here. What this is showing you is these are beam paths. So here is two different arcs where the machine will go around the patient toward their back, stop, and then come back and deliver radiation towards the front. And each one of these tick marks is actually an individual beam. So unlike my prior picture where there was only 5 beams of radiation, this uses hundreds of beams that are delivered from all different directions to give us a really nice dose distribution. And what this is showing you on the right is I can see my red line here is the 30 gray. And what I'm trying to do is give it enough to the tumor, enough to the tissue around it that might be hiding some cancer cells. We build in some wiggle room in case the patient's arm is over to the left or the right each day. And then we try to spare the bone. So you can see how the dose line is kind of breaking up here and trying to bend around the bone. But we allow the low dose to go higher to other parts, or sorry, the low dose to go to other parts of the body that we don't care as much about treating, because at that 10 gray dose, we don't see clinical effects as much. And so again, I'm trying to show you that there's this really limited high dose area, and then we allow low dose to go to more tissue to make sure those side effects aren't too bad. And so just to put this in context for you, I always like to finish my appointments with patients, kind of what I would tell my family. And basically the idea is that if you're getting radiation for a curative case in the extremity, we really should work with a multidisciplinary team to decide if we need radiation. Some cases don't, but many cases do. And these days we're usually giving it before surgery, but how much we give, when we give it, either before or after, those are going to be considerations that are just discussed in detail between the radiation doctor and the surgeon. And so that's why we really need to kind of work together to treat these patients. I also like to remind patients that they don't feel a lot during the beam delivery. You can't feel it go in or out of your body. I usually make jokes. There's no glowing or superpowers or anything like that. You don't become radioactive during these treatments. And when there are side effects, they do develop gradually. So this patient that I gave an example had a 5 treatment course of radiation. We'd expect side effects kind of towards the end of the course, more or a week after, kind of after the beams have been delivered. It's not something that you feel at the time of treatment. And in the case of an extremity, what I worry about the most is skin irritation. That's like redness or a sunburn-like effect that can show up. We help manage that with patients, but these days we use IMRT to minimize dose to the skin so that we reduce the risk of wound healing issues around the time of surgery. This is an important point. It's hard to go into too much detail today on it, but an important thing to talk about with your radiation doctor and your surgeon. We always want to protect the bone. So, if the patient's right-handed and this is their right arm, we want to make sure that that bone stays nice and strong for the future. We want them active and exercising like we talked about earlier. So we use IMRT to spare dose to the bone. We also make sure in the long term that people have good bone health with weight-bearing exercise, vitamin D, and looking for osteopenia and things like that. The last thing you'll see a lot in the literature is this stiffness or scarring. So elbow is a very mobile area. And one thing I have all my patients do, besides getting good radiation with IMRT to minimize dose, we also want to include our cancer rehab professionals, physical therapists, that can be actually delivered during radiation therapy. And so as those tissues heal after radiation and surgery, they're able to have nice mobility, really healthily recovered tissues. So that's good. So let's change gears a little bit and go to a second case. This is a patient who was diagnosed with retroperitoneal leiomyosarcoma about a year ago. And they had surgery and chemotherapy, which represents a standard treatment for this. They did well for about a year. They were doing routine surveillance CT scans. And then, unfortunately, a new lung nodule popped up about 1 centimeter. So just sitting out in the lung, something that's new. And when your doctors find new findings on surveillance scans, generally will often biopsy these to prove that it's a recurrence, and that's what happened here. So consistent with the patient's prior tumor. As always, we should have a tumor board discussion, including the patient's medical oncologist, their surgeon. In the case of a lung tumor, it might even include a thoracic surgeon. And during this discussion, we found that the patient had declining health. Unfortunately, since their surgery, they had a heart attack, they had a fall. And so the patient really is doing okay independent at home with some help from their spouse, but generally not a super healthy, fit patient due to some of these complications that have happened in their life unrelated to their cancer between their prior diagnosis and when they're having a recurrence here. And so because of that, we often pick radiotherapy as an alternative to surgery in patients who have a lung metastasis from sarcoma if we don't think they're going to be medically able to safely undergo that surgery. So this is a really good example of that. And that's what my tumor board recommended. So we wanted to give stereotactic body radiation therapy. I'm not going to wade into the complicated discussion about whether this patient needs chemotherapy now or not. But this patient's medical oncologist said, look, it's just a single spot. So why don't we give it SBRT and then we can just watch for a bit and see what happens to this patient. And so what is SBRT? And I think what's really interesting about this is that it actually doesn't have a formal definition across the world. The idea is that if you take the radiation dose and you make it very high per treatment, so instead of giving 2 or 3 gray per treatment, like they did, for example, in SARC-32, which is standard for an extremity treatment before or after surgery, we now might give something like 10 gray per treatment. And we've learned over decades that when you really amp up the dose, it changes the biology of the radiation to now make it ablative. In other words, we can kill the tumor in place with these high doses. And the thing that's cool is we really leverage this idea that if you keep the field small and you keep the high dose just in the tumor, we can actually deliver these very high doses of radiation, but with a very low chance of toxicity. And frankly, some patients have very low side effects or low chance of side effects at all with these treatments. But it's very safe. It's as safe as, for example, a modern lung resection. And so what we'll see with these patients when they get SBRT to the lung, for example, is they might have fatigue or feeling tired. We have a rare case, we have a rare complication or side effect that can happen months after treatment called pneumonitis, which is like irritation in the lung that is treatable, but it can happen, but it's quite rare. And then in the long term, as long as we deliver this in a high quality way, we have risks, things like fracturing of the ribs or bleeding, or people wonder if we're going to damage their esophagus with SBRT. It is out there in the literature, but if you do a high quality treatment that's delivered accurately, the risks of these side effects is extremely low, on the order of maybe 1%. And these fall into the bucket of side effects that I talk about with patients, which I'm guessing are very similar to the discussions surgeons might have doing a lung resection due to rare complications of anesthesia or things like that. And just as an example, I could always kind of share this if people are interested, but we have learned since 2007 that there's certain areas of the chest where we have to modulate the dose or change the way we deliver it to make sure things are safe. And in 2024, we deliver hundreds of these treatments across the world per year in every different country, and people tolerate this very well without a serious risk of complications. And so for this treatment, what we decided was, because this was far away from sensitive structures of the chest, because the patient had a lot of other medical comorbidities and it was challenging them to get to appointments, we decided to do this in a single fraction. This prescription comes out of a study in Australia that it did include patients with all different types of disease, but lung metastases, and we can give a very high dose in a single treatment, control the tumor for 2 years or more, and people can tolerate this really, really well. And I just want to point out that radiation is given in all different ways. There's lots of different ways to do this type of treatment, even for this specific case. And so if you're recommended 3 or 5 treatments or even 10, there's reasons for that sometimes. And it's important to talk to your radiation oncologist about what the prescription is and how they've decided to give the SBRT. And so we give plans the same way that I just showed you with that other case, but what I wanted to show you here is that what's special about SBRT, at least in the United States, is that when you go and lay on that table and we get ready to deliver that dose, we have one shot to hit our target. In this patient's case, for example, it's 28 gray and 1 fraction. So we bring the whole team over. At my center, we have both the physicist, who's an expert PhD level, or a lot of times master's or PhD level, expert in kind of the delivery of radiation and the quality of it. And then myself, I go over and I kind of look through everything. And one of the things we do is we take a CT scan on the machine. What this is showing you here is basically the planned CT scan in these two check boxes or checkerboard boxes here. And then I have two checkerboard boxes of today's scan. And basically I can move this little red X around and basically look at the patient's lung anatomy relative to my plan that I've designed for the patient and make sure that it looks exactly the same. And we know that if we deliver to the same spot that we plan to deliver and everything's lining up nicely, we have a very high quality treatment. So I sign off on all that stuff before the dose is actually delivered in the case of SBRT. And that's how we know it's delivered well. But I'll close out with the last case where we had a patient that, again, not a real patient here, but something that I've kind of modified with retroperitoneal leiomyosarcoma, kind of like the last case, but instead this time they have a painful spine metastasis. Sometimes in the lung, you don't feel the met, but sometimes if it shows up at a bone, you can have pain. And we take a little bit different approach just because the goal here is not to ablate the metastasis and make it go away as the only site of disease. The goal here is to try to improve the pain from the patient's painful spot. And basically, when we talk about trying to improve a symptom, we call that palliative radiation therapy. And there's lots of different ways to use it. Here are some high-level kind of ideas about palliative radiation therapy that are important. The first is because we're trying to make people feel better, we select our doses and our techniques to minimize side effects or short-term toxicities that could harm patients' quality of life. And we try to keep these treatments pretty short relative to, for example, the 5 weeks of treatment someone might get on the SARC-32 trial. We also pick our dose and fractionation based on a lot of factors. So there's really no right answer in a lot of these cases. We think about the disease. So different types of sarcoma might be more or less responsive to radiation. That might affect the dose that we pick or the dose per day that we pick. The patient's prognosis is important, the patient's function, and then the goals of treatment. Remember, in my case here, we're trying to improve pain. But I like to kind of talk about how they're not actually magic, there's science behind this, but my doctor friends and I, we all know that radiation is a really important and helpful treatment for patients with sarcoma. And it's something that we can deliver from the outside with no anesthesia and no cutting. So if a patient is feeling pretty crummy from their disease, they can come into our clinic, lay on a table, which is pretty comfortable for them, and then we can deliver the radiation and help all these things. And there are studies that show in the sarcoma world that we can improve pain, we can improve breathing in the case where lung spots are kind of blocking off airways or things like that. In other diseases, there's good studies that show we can improve time off chemotherapy in very select cases. It can improve swallowing if things are pressing on the esophagus. In the pelvic sarcoma world, it can stop bleeding if we see that happen or prevent fractures if there's bone metastases. So we have lots of different ways that radiation can be used to improve these problems. And I'll just remind everyone that sometimes we can deliver radiation very effectively in as little as a single treatment. So it can be very efficient for patients as well. So going back to our patient with the spine metastasis in the last few minutes here, this is a male patient, kind of similar story to the last case where it's a retroperitoneal leiomyosarcoma. Patient had resection. They weren't given chemotherapy just due to the details of their case, and they did pretty well overall. Unfortunately, 3 years after their treatment, they start to have pain in their mid-back, and they notice this in the context of kind of cycling. They're a very kind of high-performing person that does a lot of athletics. And when you do a PET CT, it does show this hypermetabolism in the L2 vertebral body. It's kind of like in the lower back. There's no fracture. There's no issue with the tumor pushing on the nerves. Once we get the MRI, it really just kind of shows us it's in what we call the posterior elements, which I'll show a picture in a minute. Patient's medical oncologist is getting ready to give systemic therapy to this patient for a recurrence that's been proven, but they want to know first if they can see me to get some radiation therapy to the site to help with their pain.
I want to see the picture in a second.
So what we then do is we make a multidisciplinary assessment of this patient. Whenever we're working on the spine, I have colleagues that I work with in interventional radiology, similar to me, but they do different procedures and they're radiologists at heart. They can help with we can help with biopsies or ablations or things like that that can help. And then I'm always talking to either neuro or orthopedic surgery. They often manage spine lesions in cancer centers, and they might help me think about, in a patient who's very athletic, do we need to do anything to increase the stability of the spine or address mechanical pain, which is sort of outside the scope of what I'm talking about, but we work closely together with them. And the goals for all of us together, what we're trying to do for this patient is relieve pain. If we need to, we can stabilize the bone or recover neurologic function. And in this one case, the bone was stable. There was no issue there. There was no concerns about neurologic function. And so we're really just talking about pain, and we decide radiation alone. And so as a radiation oncologist, what do I try to do as if I have a patient where I have this single spot, I want to treat it and help with their pain, what do I think about? Well, in this patient, they're very young for on average for patients with sarcoma. Remember, they were cycling many miles when this started to come up. They're an athletic person and very, very active. And I think they're going to do quite well with therapy. And so what I want to do is get that pain better as fast as possible and give the most durable control in the long term. And we have some studies in multiple different types of cancer that tell us that SBRT, or ablative radiation in the spine, is better than traditional radiation for durability and the speed of improvement. But it takes a lot more work on the patient's part and on my part. We have to do what's called a CT simulation. We usually have to have them immobilized pretty rigidly for treatment. So they might be in a position that's a little less comfortable, although feasible. And then usually it's done in multiple visits. In my clinic, I usually do 2 to 5 treatments, but sometimes you can do a bit more. And this tends to be more expensive for the healthcare system, but clearly there's benefits for this type of patient. So it is the standard of care, and there's recent guidelines in the radiotherapy world that support this kind of strategy for patients who are quite fit, doing well with a small amount of disease. But let's take the other extreme. Let's say that this is the same kind of case, but it's in a patient who maybe is 85 years old. They're not so mobile. Let's say that they are at the end of their options for standard chemotherapies or systemic therapies. And unfortunately, their medical oncologist is telling me, let's say that they have a pretty limited life expectancy. We can still help them with their pain and show great improvements in their quality of life, actually do some things to make it a bit more simple. And all we have to do is make it less dose. So we might be trading off durability of pain control, but I can get rid of the planning scan, for example. Let's say they just had a PET CT, I can plan the radiation off that and save them a visit. We can sometimes have more comfortable positions. Instead of multiple treatments, we can do just one visit. And in fact, these have become so low cost in the palliative setting that in some states, even patients on hospice can get simple single fraction palliative radiation therapy to help with their pain. It might even be a better treatment than pain medications, and even at the end of life. And so we really have a wide range of ways we can approach this, and it's become a very flexible treatment that offers goal-directed therapy for patients across a wide range of settings. So I just want to show one more picture here. This is the patient's spine that we treated. Here's the posterior element of the vertebral body, or of the spine. Here's the front of the spine. And then in this white part here is where all the nerves kind of run from their brain down to their legs to control. And you can see if this bone has cancer in it and it's near these nerves, that's why people have a lot of pain due to this thing. But the surgeons have all said that we don't actually need to do any surgery to keep this stable. They can get treatment and then they can go back to their physical activity without any further intervention. IMRT here, remember SBRT is just a dose escalated version of IMRT to basically bend the radiation dose around those spinal nerves. So you can see that I'm giving a very high dose of radiation to this tumor in the bone. But if you go just a few millimeters away, this green is kind of like the dose limit for those spinal nerves, and you can see how I've been able to spare them. And then all I have to do is have you come into my clinic. We take a picture of your spine prior to treatment, and I look and make sure it's lined up exactly the way that I expect. And I can then be confident that this dose is not going to land in near the nerves where I don't want it to land. So this is just a nice example of an SBRT treatment we were able to do for a patient with sarcoma. And so just to summarize this case, the spine is stable. We don't need any surgery here. Pain is really the only symptom, and so radiation alone is a good choice in the spine case. And I'm using SBRT again because it gives faster and more durable pain relief in a patient that I expect is going to do well for a long time and I want to get them back to their exercise as soon as possible. And so this is the best choice here. They also work, so they can only come for 1 or 2 days, and I thought I could get this done in a 2-fraction treatment, and so we were able to kind of work this out with their life otherwise. And then again, SBRT really offers the best outcome for a high-performing patient. So in my last couple minutes here, I'll just give a conclusion. The patient, overall, for all patients, radiation does have important roles in the management of sarcoma, and it's likely that each one of you will kind of hear about radiation at some point in your care for different to solve different problems throughout the sarcoma journey. The big story really is that technology added to this machine has allowed for very precise and very accurate delivery. So it is not the radiation therapy that people were getting a generation or 2 ago. It's very well tolerated, and we've been able to show that these improvements really pay off with better tumor control and better quality of life for patients in the long run. Then remember that side effects and effects to you related to radiation are going to be related to the dose, the size of the field, and the location. So it's really important to understand with your radiation oncologist kind of what to expect, because if you talk to another patient, what they experience may be unrelated entirely to what you may experience. And so it's it's a treatment that is kind of dependent on each case. But at the end of the day, it's highly effective. It has low toxicity, and we have this new biology of ablative therapies that allow us to really achieve a lot of interesting things with radiation and sarcoma. As I mentioned, I couldn't cover the whole field in 40 minutes, and so I just wanted to put some QR codes up here. We have like podcast episodes. I think we did like 4 hours of treatment on Radiotherapy 101 about the physics and radiobiology of it. We have a whole show on SBRT, which I talked about today. And I couldn't really get to proton therapy today, which does have niche uses in sarcoma, but it's something that we kind of talked about the concepts and how it's different from X-ray therapy that I mentioned throughout this talk. And then actually, Julie was very nice to offer up her case where we made a video where we actually talked about why I chose to use proton therapy in her case. The choice for this is usually quite personal to each case. And we kind of talk a lot about the pros and cons of using X-rays versus proton therapy. And we tried to give a good overview of kind of where proton therapy is very helpful in sarcoma. And that's all my slides.
Well, thank you so much for a great presentation. I pulled out about 8 or 9 questions in the chat. We may not have time for all of them, but I pulled out a few that I thought you might want to answer. And then if you have time for the other ones, you can go in and respond in the chat. But the first question is, do you see higher rates of arthritis with radiation? And you did mention it's a multi-part question. So the first is, do you see higher rates of arthritis with radiation? You did mention bone health. Are there supplements that you recommend, like vitamin D or calcium for younger patients after radiation treatment?
Yeah, that's a really good question. So what I would say to the first part is that we generally don't see arthritis. So arthritis specifically would be like inflammation or pain in the joint, and that can come from different reasons. But what we're a lot more concerned about is actually microscopic scarring in the inside the joint. We call that fibrosis. And so if you look historically in the older studies that established radiation as part of the standard of care, that was a big problem, mainly because of the size of the fields. But these days, we're able to spare the joint a lot better, and long-term fibrosis is something that we see a lot less of in a lot of patients' cases. And so I'd be more worried about stiffness as opposed to pain, but certainly joints are very complicated, and I think you certainly can have pain from radiation. It just usually doesn't manifest as like an inflammatory response like arthritis might. And then to your other question, I do recommend basically maintaining bone health. And I'll admit that I often lean on patients' primary care doctors or sometimes medical oncologists to help with that, or both. And it does include typically vitamin D and calcium. And then patients will get DEXA scans to look for osteopenia and then weight-bearing exercise. And so I sort of reinforce that recommendation, but it's very rare that I'll manage those complications myself without any other doctor's help.
Okay, thank you. Do you recommend physical therapy for all patients, or is there specific criteria for knowing when physical therapy is warranted?
Yeah, that's a really good question. So there's a website that's called Moving Through Cancer, and it gives you an idea of kind of how we might, quote, prescribe exercise for patients. I use a similar triaging method to what they recommend in kind of some of the physicians' articles, where generally, if you are exercising already at home safely, that is a very strong indicator that it's safe to continue doing that through radiation. And I do recommend it, by the way, for everyone. If people are not exercisers or they might feel unsteady on their feet, for example, and they tell me they want to be walking, then I'll actually connect them with a physical therapist. And so, long story short, is I do recommend it for everyone. How we get that done will vary from patient to patient.
Okay, last question. I think we only have time for one more, but can radiation be given on lymph nodes?
Yeah, that's a great question. So, and by the way, I'll try to answer some of these questions in the chat, like via text
Thank
after
you.
this. Yeah, so it generally we will. So if lymph nodes involve disease, which is somewhat rare in the sarcoma world, we do include it. Because it's rare, we often don't include it electively. So you might hear of including lymph nodes in a radiation field, like in the breast world, for example, or in the head and neck cancer world. But in sarcoma, we don't do that electively without evidence of disease. But if it needs to be treated, it's something that we have a lot of experience treating with a lot of other cancers, and so we'll routinely do that. And that is another thing that has gotten a lot safer and less toxic over the years.
Okay, great. Well, thank you so much for your